Matt Southwell. Please, welcome. I will introduce you in Swedish, if that's okay, so you can't deny if I lie. Matt är rådgivare och global talesman om narkotika och HIV. Han är partner i det helägda COACT, ett internationellt supportkooperativ som är specialiserat på droganvändares organisering och skademinskning och psykosociala läkemedelsbehandlingar, helt enkelt. Han har skrivit tekniska riktlinjer och opinionsbildande dokument för FN och andra internationella icke-statliga organisationer. Han är anställd av nätverket PWUD, säger man det? Ja, får se. People Who Use Drugs, är det en förkortning för? Och han är aktiv i etableringen av det europeiska nätverket Euro-MPOD, som är människor i Europa som använder droger, helt enkelt. Och för närvarande så arbetar han också i UNODC, United Nations Office on Drugs and Crime, för att skriva strategin för deras globala AIDS-program. Och han har också en passion för Afghanistan, that word you recognize, yeah, Afghanistan, där han stöder utvecklingen av den brukarledda organisationen Bridge. Matt har också representerat International Network of People Who Use Drugs, som ni kanske har hört talas om. IMPOD är den förkortningen av det nätverket. Och har varit med i styrelsen för UNAIDS under 3 år. Så han har ett digert CV, den här mannen. Och han kommer att prata under rubriken Exempel, lärdomar och möjligheter från global aktivism av och för människor som använder narkotika. Men eftersom Matt är engelsman så är detta anförande på engelska. Så att ni får hojta till om det är någonting ni vill ha förtydligat eller inte riktigt begriper, eller om man ska prata långsammare eller så. Annars så överlämnar jag ordet till Matt. Did you put on your mic?
I have, yep.
Okay, so you're ready to introduce now, so
thank you.
Please, once again, welcome.
Thank you very much. I feel like Madonna with this headphones. Okay, I'm going to try and speak slowly enough so that you can understand me. Please go like this if I speak too fast. Just to give you a background to what I'm going to talk about. I'm going to talk about the role of people who use drugs in global advocacy. And I want to draw some lessons for drug users based on my own experience of being a global advocate. And I also want to particularly look at some of the key global advocacy opportunities that are coming in front of us. To give you a little bit of background about me, I was originally one of the UK's first harm reduction workers. I was running needle exchange and HIV treatment services in East London, which is one of the most poor areas of East London and one of the most diverse areas of London. And at that time I was not a public drug user. I was on a journey as a health service manager. And for 10 years I was part of the UK's HIV response. My team was known for employing drug users, but everybody assumed that me as the boss, I wasn't a drug user, that it was probably the outreach workers and the other people who were drug users in my team. People were quite surprised when they found out that actually 50% of my management team were actually drug users. So in 1999 I decided to come out publicly as a drug user, and I did a TV documentary where I spoke about my experience as a drug user. And that caused some tensions within the drugs field because I was a very senior manager. And there was a sort of sense for some people of almost like a betrayal that I'd gone over to the drug users, that I'd abandoned the professional field and sided with the drug users. Whereas for me, what I see my role as is bridge building. Is I am a professional and I also am a drug user, and those two things coexist. And what I try to do is be a bridge between the two worlds so that we can try to create better understanding so that professional services can respond better to drug users and drug users can work better with professional services. And I think part of that journey is understanding that we make mistakes, because when you're trying to work in different contexts and different environments, we don't always get it right. And I think one of the things that we need to learn to do is to have a dialogue, even when we don't agree with each other, so that we can move things forward. I think you've been explained about my advocacy roles and the other work that I do, so I won't go into that. So what I'm just going to do to start with is just describe some of the UN divisions that have a relationship with drugs, just to explain a little bit about how the global architecture works. So the first part that I got involved in was the UN Office of Drugs and Crime. So this is the division of the UN that is responsible for drugs, but is responsible particularly for the drug control elements, although it also has responsibility for the HIV response with people who inject drugs, and also the drug treatment response. But I think it's fair to say the drug control work dominates in terms of scale. So within this world, it's a Vienna-based piece of work. The people who attend the different boards of UNODC, which is the Commission on Narcotic Drugs and the Crime Commission, so very much about the drug response, but from a justice perspective. So all the people who go to the committees to discuss drugs are not public health workers, they are justice workers, so they're the police, the justice departments. And that provides a challenge, because it means the people designing the response to people who use drugs frame us as criminals from the start, rather than seeing us as subjects of a public health response. So I was lucky enough to be, along with Damon, to be invited to sit on the UK's team reporting to the Commission on Narcotic, the UK team going to the Commission on Narcotic Drugs, and Damon and I were both civil society representatives. And it was very interesting to be an active drug user sitting on a government panel, and it did create limitations of what I could say, but it also was an incredibly useful training in diplomacy. And I think I want to come back to this diplomatic world that we're trying to operate in, because it's very alien to what we're used to as activists. So I sat on the committee for 2 years. I sat on the Commission on Narcotic Drugs for 2 years as a country representative. I then actually was arrested in another country and spent 2 weeks in jail, which led the British to decide I probably wasn't the best person to sit on the panel. But on the other hand, for me, that was part of the realities of being a drug user. Is that we get arrested, that's part of our reality. So that was 2 years, and what I learnt in that 2 years was that the Commission on Narcotic Drugs is incredibly polarised. So you have people who are committed to harm reduction, to drug user rights, and to moving things forward in a progressive way. And then you have people who are vehemently opposed to drugs and defending of prohibition. So you have these two highly polarised groups, and this polarisation exists both among country missions, and it also exists within civil society, and it also exists among diplomats. But of course it's not static. So we've seen particularly the US, for example, change their position. And I was there just as Bush left office and Obama came into office. And we saw a significant impact of the world's strongest supporter of prohibition suddenly changing position and becoming pro-treatment, pro-harm reduction. Now that's then left Russia and various different Muslim countries being the really strong advocates of prohibition. But it shows how this world is fluid and changes. It's not a fixed process. So for example, we've seen countries like Hungary at one point being very, very progressive, supporting drug law reform, and now, because of a conservative government coming in, swinging back and taking the opposite position. So we have to, you're always looking at these changing coalitions that are going on. And one of the challenges in this setting is that it works by consensus. So you're trying to form a consensus between people who fundamentally disagree with each other. Now, in principle, that's great. And it's great that we should be trying to work towards consensus and trying to find ways of working with each other. But in practice, it's disastrous, because it means we always operate to the lowest common denominator. So basically, when you're negotiating to get through the bits that everybody supports. But that means a lot of things don't get supported, even though the science backs them completely, because it's not ideologically part of the government position. So this is one of the challenges. I did 2 years at the Commission on Narcotic Drugs and decided really that I didn't think there was room to achieve change in that setting. So I then relocated my time as a global advocate to work with the UNAIDS, UN's Joint AIDS Programme, and I'll come back to that in a minute. So we have this drug control environment which is highly, highly polarised. And we are about to come up to a key meeting called UNGAS, or the UN General Assembly on Drugs in 2016. And the negotiations for that meeting have been going for the last 2 years or so. So we are at a critical moment in the discussion of global drug policy. But in reality, I think we're all reasonably pessimistic about what will actually come out of that commission, out of that review. Civil society is hoping, or at least the progressive elements of civil society, are hoping that we can come out of that meeting with at least a commitment to understanding that people who use drugs should not be criminalised. And the UNODC now is overtly saying, we recognise that even within the current drug control conventions, there is no point at which it says you must criminalise drug users. That's been how the conventions have been interpreted. So the banning of drugs has been equated with the criminalising of people who use drugs. But actually the conventions don't require you to criminalise people who use drugs, which is why experiments in Uruguay, in the United States, in Portugal are all acceptable within the drug control conventions. And we are just waiting for UNODC to come out with a statement where they actually make this explicit and say, we want to be clear that the drug control conventions do not require you as a government to criminalise people who use drugs. Now, will we get that in 2016 at UNGAS? Absolutely not. Now, of course, some people would like a much more full change to the drug control system, but the fact that we can't even get a statement that drug users shouldn't be criminalised shows how far we've got to go. And there are people who quite explicitly will say drug users don't deserve human rights because we're not somehow human. By stepping outside the accepted standards of what is expected of a human being, we somehow become dehumanized. And so, and I've explicitly heard, for example, the representative of Egypt at a UNAIDS board meeting saying people have rights the moment they become HIV positive, because then they become patients. Prior to that, people do not have rights. So you do not have rights as a drug user, you do not have rights as a gay man, you do not have rights as a sex worker or as a transgender person. You only get rights when you become infected with HIV. So we can see that we are in this very difficult dilemma where for many of us we are saying there is an intrinsic human right, the human right to life, the human right to be free of incarceration, the right to health. All of these different elements are key within the UN conventions. But for our populations, for our people, somehow we are excluded from those universal functions. So, I then moved over from Vienna to working in Geneva, which is where the public health part of the UN is based. And the lead organisation for health is the World Health Organization, which is a powerful organisation. It's what brings together all the different ministries of public health from around the world. It's science-based, and it comes out with normative guidance. It comes out with guidelines that tell people how you should respond to different issues. And those guidelines are driven by the science, so they have this very complex process that they go through to assess the evidence. And they weigh up the evidence using this formula called PICO, and based on the evidence, they write new guidance. So this is where science is more often leading, whereas in the criminal justice world of CND, the science is often ignored. The problem with the World Health Organization is that it doesn't have many resources for drug treatment, and it doesn't have many resources for HIV. So even though it would be naturally a useful agency, it has very limited resources to engage in work that we would want it to be doing. However, we also know that the WHO can be very slow to act. For example, it took them a very long time to embrace hepatitis C as a new issue. But once the World Health Assembly, the governing body of the World Health Organization, decided that hepatitis C was a priority, then quickly we got normative guidance, quickly we start to see changes being pushed around the world around how hepatitis is responded to. So once the WHO is given a mandate, it can be effective and dynamic. The challenge is that it has limited resources. In terms of HIV specifically, there is something called UNAIDS, the UN Joint Programme on AIDS. Now, the UNAIDS is different from other parts of the UN. It is a joint programme, so it basically brings together 11 different divisions of the UN to plan the HIV response. So it's not a UN division in a traditional sense, it's a coalition of all the different UN divisions working together. And UNODC, the UN Office of Drugs and Crime, has the lead both for people in prison and also for people who use drugs, or predominantly people who inject drugs. Now, let's not underestimate what UNAIDS has done. Through its coordinated strategy, we have seen fundamental change in certain areas. So, for example, among what's called PMTC, prevention of mother-to-child transmission, we have seen fundamental change around the world. Even Russia has made substantial progress around PMTC. So we are now confidently looking forward to a future where no baby will be born living with HIV. That's a confident, we can now confidently say that we are well on the way to achieving that goal. So it shows that when the UN and everybody can find consensus, real progress can be made. However, we set ourselves the target, or the UN set itself the target to achieve by 2015 a halving of HIV infections among people who inject drugs. Now, we have a problem that we actually don't know how many people who inject drugs there are in the world, which makes measuring our progress somewhat difficult. However, we know that actually HIV among people who people who inject drugs is going up, not down. So, in fact, people who injecting drug use is the driver of the epidemic in Eastern Europe, in Asia, and increasingly now in Africa as well. So, what we have is, among mothers and children, a nice neutral population that the world finds easy to embrace. We can make substantial progress, and the UNAIDS joint programme can be highly effective. But when it comes to people who inject drugs, we have not made any progress towards that target. In fact, we have made negative progress. We're going backwards, not forwards. So let me just ask you a question. This is where I want you to be a bit interactive. What do you think are the reasons why we have made progress with mothers and children, but not with people who inject drugs? What would be your guess? What reasons?
It's more likable.
So mothers and children are much more cuddly and nice than injecting drug users? Yep. So building the consensus is easier. Other reasons?
Jag kommer med micken om du vill ha en lång utläggning.
It's not illegal to have children, so the fact that people who inject drugs are criminalised all over the world, we are universally criminalised, is a key barrier to change. Other issues might be getting in the way.
The mother's health care.
The mother's
health care.
So yes, the underlying infrastructure for mothers and children, for pregnancy and maternal health tend to exist already in countries, whereas the infrastructure for people who use drugs in many countries doesn't exist. So you're having to start from zero rather than building on an existing health system. So you can see that there are key reasons why we are not making progress. Criminalisation, stigma and discrimination, a lack of systems already existing, the challenge of trying to persuade people to fund things that are unpopular, populations that people don't like. But the reality is that we know what works. We absolutely know what works. The UN Office of Drugs and Crime, UNAIDS and the WHO came out with a guideline called the Technical Guide for Injecting Drug Use and HIV, which sets out 9 different interventions that are known to work among people who inject drugs. Now, there's a difficulty sometimes of using the words harm reduction, but in terms of understanding HIV prevention among people who inject drugs, we know that needle exchange, opiate substitution therapy, voluntary testing and counselling, and access to antiretroviral treatments, these are the 4 dominant interventions that if you have those 4 interventions in your country, you will turn your HIV epidemic. We know it works. We've seen it work in multiple countries. But the problem is we can't get to the point where countries universally implement the science. Even though the WHO and the UN Office of Drugs and Crime and UNAIDS have all said to governments, categorically, this is what works. So we are stuck in the situation of not knowing how to respond to people who inject drugs, or at least not being able to respond to people who inject drugs. And we have Russia as a key agent in the world, which is fighting against the science, trying to lobby and block any progress. Now, people can argue why that is happening. People might say that there are people high up in the Russian government who are heavily complicit in the drugs trade, and Russia is largely a narco state, and that is one of the key barriers to change. The problem is we have new HIV epidemics among people who inject drugs. So, for example, we now see new epidemics among people who smoke stimulants. We're seeing in Latin America, in the Caribbean and in Asia, people smoking methamphetamine or piping crack, and they are getting HIV. So there's no direct transmission route, but this population is getting HIV. We're also seeing the rise of what's called chemsex among men who have sex with men. So we're now seeing a spread of injecting drug use, particularly methamphetamine use, among gay men. And that's starting in Western Europe to lead to a new HIV epidemic among a population that previously we'd actually done really well in terms of driving down the epidemic. So the problem is, because we don't respond to HIV effectively among injecting drug users, we're also not responding effectively to other populations as well. So let me ask you, so I'm going to do a bit of interactive stuff, so let's try and get this to work. Why do you think people who smoke stimulants are at risk from HIV?
They have low life expectancy. They don't take care of us.
Yeah, so just the fact that your immune system is weakened, you're not looking after your body in the same way, so you're more vulnerable to infection. Sex. Yeah, so the key transmission route is sex, but it's compounded by the high risk behaviour that goes with smoking stimulants. What else? Other factors? It's a hard one. What were your answers around injecting? Think about some of the answers we came out with before. So criminalisation. This is a population predominantly of sex workers and also of people smoking crack cocaine. Arguably the most demonised population of drug users other than injectors. So you've got a highly stigmatised populations who are dual stigmatised because they're often sex workers or MSM, transgender and taking drugs. They're extremely poor. So we're often seeing this among the most poor people, the most marginalised people. And it really highlights the fact that we know the HIV epidemic exposes the fault lines of the social failures in our society. That's the problem. So of course injecting drug users are affected by HIV directly because of the transmission route that takes place when you stick a needle in your arm and you've shared a used syringe. But those people who inject drugs are not just vulnerable because of their injecting drug use. They're also vulnerable because of poverty, because of criminalisation, because of social exclusion, because of stigma and discrimination. And smoking, the epidemics of HIV among people who pipe stimulants really emphasises that. Because when you take away the injecting transmission route, we're still seeing drug users becoming infected with HIV. So it highlights that yes, we need to tackle needless exchange, opiate substitution therapy, voluntary testing and counselling, and antiretroviral treatments, but we also have to address the legal environment. Because if we don't address the legal environment, then we're not dealing with this wider range of factors that are really impacting on the HIV epidemic. And that's where we face this real challenge, because we have the UN Office of Drugs and Crime creating a drug control environment that criminalises and persecutes one of the key populations affected by HIV. At the same time, they're breaching the fundamental UN mandate to support the human rights of all citizens around the world. So we find ourselves in a situation where the UN Office of Drugs and Crime is effectively breaking the UN's conventions on human rights through its use of the drug control regulations. And this has taken us into a new domain of work, which Damon and people at Harm Reduction International have been real pioneers in working around, which is looking at the aspect of human rights. And this takes place through the UN Development Programme, and they ran particularly something called the Global Commission on HIV and the Law. And that was brought together some very eminent people to talk about the impact of the legal environment. And that really showed us that the legal environment has a huge impact on HIV vulnerability. And so we know that within the context of highly criminalised, highly demonised environments, drug users and any other key population are far more vulnerable to HIV than in systems like Sweden, where you have a much more strong welfare state and a strong supporting environment. And one of the particular challenges is when you mix a highly prohibition-orientated system with huge poverty, inequity, lack of healthcare systems that take place in the global south, then you get something that's very different. And so one of my frustrations is we're often debating at the global level between global north countries that are well-resourced, have good health systems, good social care systems, debating technicalities of policy that when they are applied to countries like Afghanistan, Vietnam, Cambodia, Tanzania, whatever, then in those countries there's a totally different experience of those interventions. Because, I work with drug users in Afghanistan, there is no welfare state. When drug users have abscesses, they die because they cannot go to accident and emergency departments because of the stigma and discrimination that exists against them. So that means that a small issue like an injecting-related injury. I'm an injecting drug user, and I had a very serious abscess on my bottom and lost about a third of my buttock at one point. Now, I went through a 3-month period of treatment to recover from that. I know that my peers in Afghanistan would have died from that intervention, would have died from that. And I see when I walk around, when I was last in Afghanistan a few weeks ago, we saw a guy with full necrotitis of his arm. His arm had basically rotted. And we were trying to get a hospital to take him in and amputate his arm. And we couldn't get one to take him in. And 2 days after we left, he died. And in the winter, we're seeing in Afghanistan 1 or 2 people dying every single day from hypothermia, from overdose rates, from the use of methamphetamine that's now come into the country. So we're starting to see in these countries the impact of poorly thought through drug control is devastating. And I think it's very important that we manage in the global debate the differences for countries that are highly marginalised compared with countries that are resource rich. Okay, so we then come back to how do we then drive forward change in countries that are very poor. Now, one of the key mechanisms that the world has developed is the Global Fund for TB, HIV and malaria. And this is the world's biggest donor, again based in Geneva. And many governments give money to the Global Fund to disperse around the world. And look, these are very large-scale grants. These are like $30 million grants to help the whole country respond to HIV. And we've been working with Afghanistan as part of their application to get $9 million of HIV funding for the next 3 years. And to give you an indication, that would be a 4-fold increase in treatment services and HIV prevention and treatment services. So the Global Fund has been a very, very important agent, because in Eastern Europe, where there's huge political hostility towards harm reduction, and even in Russia, the needle exchange programs have been funded by the Global Fund. So it's allowed the global community to directly invest in countries and support key populations who are most marginalised and at risk, even when the governments are not willing to do that. However, the challenge that we now face is that the Global Fund has changed its funding criteria. And they're now saying that they want to focus their money on countries with high prevalence and low income. Now, that's great. That picks up most generalised epidemics around the world. The problem is what's called concentrated epidemics, epidemics that take place among the key populations, people who inject drugs, men who have sex with men, transgender people, and sex workers. In those populations and those epidemics tend to exist in middle to high income countries. So the Global Fund is actually stepping back from funding concentrated epidemics among people who, among the key populations. And let me give you an illustration of that. In Romania, they had a Global Fund program that funded their needle exchange programs. And they were very successful. They meant that HIV levels in Romania were very low, and they were successful at stopping HIV coming into the country. Romania was doing well in terms of its development, the development of its economy, and therefore moved into middle-income status, or high-income status. At that point, the Global Fund decided to stop their funding. Now, the head of the Romanian Harm Reduction Association said at the time, this is a catastrophic mistake. You're taking away the very thing that has allowed us to be successful. You're using our success as a reason for taking away our funding. What happened as a result was methadone arrived in Romania. People started injecting methadone. The needle exchanges had been closed because the Global Fund money was withdrawn. The government hadn't stepped in to fund needle exchange because they didn't support needle exchange and harm reduction. And then there was a mass outbreak of HIV among people injecting methadone. So then the Global Fund had to step back in again and refund the harm reduction programs that were taking place. So one of the key challenges that we've got globally is how we persuade countries to start picking up funding and funding things domestically that we know are very, very unpopular. For example, in the UK, my government now is a Conservative government that has decided to change the priorities around HIV. We were one of the great champions of harm reduction. In fact, it used to be called the British model. But now we've moved towards a much more punitive, recovery-based model, and the government has decided that the best priorities are women and children, because they're easily to support. Now, the loss of the British government as a backer of harm reduction in the global system is significant. They're a major donor, and they were a very strong country in terms of backing harm reduction. But we've now lost them because the government has shifted its priorities to something safer and easier to support. So, in the next period, we have 3 key advocacy events that are coming up. One is the UN General Assembly on Drugs in 2016, which will revisit the drug control conventions. The reality is we expect very little from this. because we have to find consensus, and we know that Russia is going to block consensus whatever happens, and the various countries that coalesce around Russia will block any progress around change. Now, the fact that these people deny the science, so that Russia says OST does not work, despite the WHO saying it categorically does, means that we're in a debate with justice officers about a public health response. So we have the WHO on one hand saying, this is the normative guidance, this is what you should do, and then justice departments are saying, no, we don't want to do that. So one of the things that we're doing with UNAIDS as civil society is trying to take the learning from the health response to HIV into the discussion on UNGAS. So we're trying to get the Geneva missions to talk to their New York missions to say, listen, we have learned really important things from the HIV epidemic. You need to recognise this as the people taking forward the debate in New York. And this is where there's a whole series of civil society engagement around this process. Now, the reality is we may not achieve change in 2016, but this change is incremental. And we have made progress over time. It's slow and painful, and you need to stay engaged over the long term to achieve longer term progress. But it's frustrating and it's slow work. When I come back from seeing my peers dying, living under bridges in Afghanistan, I get very, very impatient when I'm sitting in UN meetings, listening to diplomats telling me how perfect their systems are, how wonderful their work is, how black is white, how green is blue. And you listen to these speeches, and for me as a peer, I just remember the people I've seen, the friends I've lost from the HIV epidemic, and it just feels very, very distant from the reality. But we need to stay engaged. And that's the challenge. The other issue is that we've had something called the Millennium Development Goals, which again were based around 2015. This was where we had these targets around halving HIV infections. We're now moving into something called Sustainable Development Goals, which is a more comprehensive set of goals that aren't just health-based, that look at development in the broader sense. And we will have a dedicated SDG on HIV, but also ones on justice, ones on sexual health, sexual and reproductive health, that all impact on people who use drugs. And again, this is very technical work, but it's about setting the global standards for how this work is done. And we're also coming up, we're about 2 years out from the high-level meeting on HIV, which again will be another chance to review the HIV epidemic, setting targets for now 2030. Now, what's really interesting around the new targets on HIV is that what the UNAs have worked out is if we do not change approach and embrace what is known to work within the next 5 years, it is impossible to achieve the targets by 2030. Because if you do not start to change now, you get more and more people become infected, therefore the pool of infection is greater. You've got less people in treatment, so you're not getting the suppressive effect on viral load that stops people becoming more infectious to other people. So we have a clear warning from UNAIDS. You have to invest now in the next 5 years to achieve change, and if you don't do it, you will have failed the 2030 targets by 2020. Now that's really, really concerning, because we have substantial barriers to change. I mean, Russia is not going to suddenly change position in the next 5 years, and they have the biggest population of injecting drug users in the world. And if we don't get Russia to change, then realistically we are not going to make progress around the targets for people who inject drugs. Alongside these agendas, there are also ongoing debates that we're having, which are very dry. Debates like Harm Reduction International are involved in debates around data. But if we don't measure things correctly, how do we know that change is taking place? So, for example, there is something called the World Drugs Report, which is published each year, and there's huge debates around what are those figures, where do these figures come from, how do these figures show that things have changed? So again, that's a piece of work that continues to be done. The other is to try to get high and middle income countries to switch to domestic investment, that we need to move away from a dependence on external donors to increasingly, in these increasingly rich countries, to actually fund their own response to harm reduction. But that creates a huge challenge in countries that are demonising drug users quite openly. We've seen in Central Europe, for example, drug users becoming part of the political discourse. I was in the Czech Republic seeing posters from the fascist parties up on the walls saying, no, kill all junkies, no, really demonising drug users as part of the political process. And these are the people we need to persuade to now invest in harm reduction services. We're also coming up in October to the resetting of the budget, what's called the UBRAF, the Unified Budget and Results and Accountability Framework. Again, very, very dry, boring work, but it sets the budget for the HIV response. Now, we're looking at the United Nations Office of Drugs and Crime is likely to get either a static budget, so the same money as last year, or a decreasing budget, just at the point when we need to scale up the response to HIV. So that's a huge problem in terms of the fact that we're not investing the money we need to invest to make change. And at the same time, we're also seeing crises around the world. Mauritius has just decided not to invest in OST anymore, and not to invest in methadone, to end their methadone programs. Kenya is now deciding that it's ambivalent around methadone. Afghanistan is in the middle of a fully fledged attack on drug users from the local police. So these crises break out around the world, and we also know that there's a huge problem for drug users in the middle of war zones and war conflicts where treatment is also disengaged with. So this is the context. So what I want to ask you is, what do you think is the role of drug users in this world of global advocacy? What do you think is the role of us as people who use drugs as global advocates? Which is?
Giving out knowledge.
Okay, so knowledge sharing. We can bear testimony to the experience of people who use drugs. Ethan Nailman described it as, we can make people cry, because we can tell personal testimony that cuts through the science and and creates global empathy, an empathic connection with people. Why else might drug users be useful as global advocates?
Peer action.
Yeah, so actually we can respond to situations that other people aren't responding to. I know Bernie's work in Sweden, for example, has been instrumental in bringing around legal exchange. When governments were saying we're ambivalent, drug users stepped in and did the work themselves. And this has happened around the world. We've seen this in many, many situations. Why else? What else? What other reasons might drug users be good at global advocates? Networking, yeah. So, and I think this is a key part of this process. We are good at some things and not so good at other things, because we're seen as very invested in the outcome of drug policy, for example. So if I stand up as a drug user and say, I believe in drug law reform, people are going to go, of course you are. No, you're totally invested as a drug user in drug law reform. You're not objective in that discussion. So that's why I work with the International Drug Policy Consortium, because that message being given by the police or being given by academics or other people may have more impact than it's been given by me as a drug user. So we want to work in alliances because we know that some things we do well and other things we're not so good at doing. We're also good at being technical experts. Bill Zill, for example, introduced low dead space syringes, these needles that cut out this small amount of blood that sits in the top of barrels, of syringes. Now Bob's work has gone on to create WHO guidelines that support low dead space syringes. So this is a drug user, ex-drug user, doing research, implementing a new technology that is now embraced by the WHO. And the other thing I think we all have, and I think this is a responsibility for those of us in the global north, is that our countries are the big donor countries. So, for example, in the UK, it's not good enough for me just to complain about the fact that the UK has shifted its funding commitments. I need to be advocating at a domestic level to get the UK to understand the implications of switching its funding from harm reduction to mothers and children. And I think, no, as Swedish drug users, you need to be doing the similar process as I see you doing here, to engage your politicians in a discussion about how progress moves forward. So, how am I doing for time? I think, am I pretty much done for time? Or?
Have some time for questions as well. Yeah.
Okay, so I just want to just pick up some last just lessons that I've learned in the last period from doing this work. The first is that diplomacy is a very strange world. I've never been insulted so politely in my life. It's a really strange environment. You don't ever mention countries, for example. You can never name a country and shame a country for its practice. So you have to learn diplomatic protocol. And sometimes we as activists it's a bit like being rugby players coming into a football match. And people then start to be surprised when we pick up the ball and starting to run with it and tackle people. It's because we're playing the wrong game in the wrong place. And I think we need to learn that activism is an important function, but actually diplomacy is not activism. They're different functions. And we need to learn how to use diplomatic skills to work in these environments. So for example, one of the things I will always do is wear a suit. I've got rid of my earrings, my coloured hair and the various other things over the years, because I'm serious enough about fighting for drug user rights to look as straight as possible. Because then when people talk to me, that other stuff of me being other than them isn't immediately in play. So I remember very well an American diplomat being introduced to me by the British delegation, and I was introduced as a member of civil society, and when she realised I was a drug user, she literally jumped back 2 steps. And it was this interesting process of actually, I completely challenged her stereotypes about what drug users should look like. And I often get this statement of, you're not a typical drug user, which actually just highlights people's stereotypes around drug use. The other thing is that within this process, you've got to be able to build and expend political capital. So this basically means that you play the game, you work within the system, you build up credibility through working with the system, and at key moments, you might then dissent. The problem is if you always dissent, and you're always opposing the system, then people just get used to that being your way of working. So one of the tactics is to learn when to dissent and when to play the game, and to use that in a skillful, strategic way. And the other thing is that we have to work in partnership. There's multiple functions going on in this diplomacy world, and the way for us, as drug users, we can't play all of those roles. We have a critical role to play, but the role is best played by working in partnership with other people. And a final lesson is that the most powerful people in the system are the countries. They are the people who the UN ultimately listen to. So one of our key functions as advocates is to bring the countries on board behind harm reduction. So lobbying our countries, working with different countries, is a critical way of working because they're the big heavy hitters. Civil society has some impact, but countries have substantial impact. That's it.
Thank you so much, Matt. Are there any questions? Några frågor till Matt? An activist, you can.
Just thank you very much. Short question. You seem very pessimistic about gas. Is that your point of view?
Yeah, I mean, I wish I started off being optimistic around gas. No, there was the potential. We started to see different countries around the world changing. The balance of countries now is different than it was when I first started doing advocacy 5, 6, 7 years ago. So theoretically, if you were having a voting system, we've now got more and more people supporting our cause. The problem is it's a consensus-based model, so the recalcitrant countries like Russia hold everybody else back from making change. And that's why I'm pessimistic.
So Russia has a veto in UNGAS.
Well, effectively, every country has a veto, so you're always trying to work towards consensus rather than... I mean, you theoretically can call a vote, but it's highly unusual and always guarded against. So you're always trying to form a consensus, which always means you go to the bottom of the consensus. It's always the least controversial position is what everybody signs up to. So it's an incredibly challenging process to move forward.
So how do you keep working within the UN without getting super depressed?
Yeah, so one of the reasons I do 3.5 days a month on global advocacy is for that very reason. For me, it's about working some of my time in global advocacy and then working in countries like Afghanistan where I feel I have a much more direct impact in terms of my work. But there are also mechanisms. I mean, in UNAIDS, for example, there's something after every board meeting we have something called the thematic day where we sit down and discuss issues without voting. And that just allows the culture change to start to take place, that you start to discuss the legal environment, you discuss stigma and discrimination, but you're not forcing anybody to come to a position, and that starts to influence people around their behaviour. Recently at the Commission on Narcotic Drugs there was a scientific panel where a load of scientists came together to say this is what works, and that produced a set of guidance which didn't have to go in front of the whole CND to be voted on. So there are clever ways of working in diplomacy that get issues put forward, but it's challenging, it is.
Thank you.
Okay, once again a big applause for Matt, please.
Thank you so much.